started. We are very pleased to welcome Dr. Martha Spencer, who is a clinical expert on the topic of geriatric incontinence. Dr. Spencer is a practicing internist and geriatrician at St. Paul's Hospital in Vancouver and a clinical instructor at the University of British Columbia. Her current practice consists of acute internal medicine on the clinical teaching unit, as well as geriatric medicine inpatient consult and outreach work. Her clinical interests include geriatric continence and medical education. And Dr. Spencer is also the founder of a novel multidisciplinary continence clinic that specializes in medical approaches to bladder and bowel continence. Before we hand over to Dr. Spencer, I'd just like to mention that she will take questions and comments at the end of the presentation, but please feel free to have dialogue in the chat box throughout the presentation. So just go ahead and type your comments and questions in the chat box at any time in the presentation, and Dr. Spencer will address them at the end. And with that, I'd like to invite Dr. Spencer to take the stage. Welcome.
Great, thank you. Just going to get my presentation here. Great. So yes, thank you very much for the kind introduction. So my name is Martha Spencer, and as mentioned, I'm a geriatrician here in Vancouver. It's only 9 a.m. here, and I know it's later for you guys. You guys are probably eating your lunch by now, or as it's still breakfast time here in Vancouver. So I would like to start today actually by giving you guys a poll question to start the day. And my first question, which is probably the most important question in my presentation, is I want you guys to think about this and answer, is urinary incontinence an expected consequence of aging? True or false? So I'll just wait for your answers to this. All right, so we have false at 83% and true at 17%. So I'm very, very glad that the majority of you chose false for that that answer. So urinary incontinence is not a normal part of aging, and this is really something that we should be sharing with all of our patients because we really do want them to come forward with their symptoms of incontinence, because as I'm hoping to demonstrate to you through this presentation today, there's actually a lot that we can do to help older people with incontinence to improve their symptoms and sometimes even cure their symptoms altogether. So I do, as I mentioned, I want you to spread the word that urinary incontinence is not a normal part of aging. And if this is all you take out from my presentation today, I think that would be actually fine with me. So I want to start with the fact that there are obviously, urinary incontinence is not a normal part of aging, but there are some normal changes that happen with the urinary tract as we get older. So in the bladder, we develop decreased bladder capacity. We get decreased sensation to filling, which is why older people often retain more in their bladders than younger people. So for example, if we do a post-void residual on older people, sometimes they will have some left over in their bladder, and that can be completely normal in an older person. Older people have increased detrusor overactivity, making them more apt to get overactive bladder. They have decreased contractile function due to replacement of elastic tissue by fibrotic tissue. And as mentioned, they do have an increased post-void residual. There is a decreased urethral closure pressure in women, and certainly older women do have higher rates of stress incontinence because of this issue. There's increased nighttime urine production, and this is an important issue because nocturia is a very bothersome symptom to many older adults. And when we're younger, we have a peak of antidiuretic hormone that occurs overnight, and this prevents us from being up all night having to empty our bladder. As we get older, however, sometimes this antidiuretic peak will start to flatten out, and sometimes flatten out completely so that we don't get that ADH surge at nighttime, therefore making us have to get up several times at night to void. There are ways to get around this, such as replacing your antidiuretic hormone by using desmopressin to replace this in older adults. And this can be a very, very bothersome symptom. We also have altered central and peripheral neurotransmitter concentrations, and older people do tend to get increased white matter hypodensities in the brain. And this is certainly the case for older adults who have multiple vascular risk factors. And we know that white matter hypodensities do tend to accumulate primarily in the frontal lobe, at least early in disease. And the frontal lobe has major control over the bladder. It's the part of the brain that decides whether it's appropriate for the bladder to empty or not. For example, when we're in the middle of a grocery store. So if we do tend to get increased hypodensities in the front of the brain, as many people do with aging, some of that control of bladder function may be impaired. So urinary incontinence is very common in older adults. So internationally, the prevalence is estimated at anywhere from 30 to 65%, with prevalence of dual incontinence also in the same range. That means both fecal and urinary incontinence. The Canadian estimates are similar, up to 50%, so affecting millions of Canadians. And this is really the reason why I'm asking you guys to be the ones at the front line screening for this problem, because it is so prevalent and is such an important problem to our population. I really can't think of any health problem that's perhaps as prevalent as this one. We do know, however, that urinary incontinence is both underdiagnosed and undertreated. And this is probably due to a number of factors. So first of all, patients are embarrassed coming forward with their incontinence symptoms, hence the need to screen. Incontinence is not a normal part of aging, as I've already said many times, but there is that belief out there, both on the part of patients and healthcare providers, that this is the case, and therefore there's no sense of screening for it or trying to treat it. And there does seem to be a lack of motivation to investigate urinary incontinence in older adults on the part of healthcare practitioners. This has been found in a few studies, likely due to the false belief that it's not an important problem and it's just a natural part of getting older. So I think that, historically urinary incontinence has been typically managed by surgeons. So urogynecologists, urologists generally have seen patients for this important problem. But I would argue that there are many, many medical problems that also affect incontinence and can create incontinence in older adults. And obviously this becomes more important as people get older and accumulate a wider range of health conditions. So here's just a laundry list of different medical conditions that can cause incontinence, many of which you see every day. So peripheral vascular disease, diabetes, congestive heart failure, chronic venous insufficiency leading to leg edema, lung diseases, dementia, different types of Parkinsonism, constipation. Stroke is a big one. We see a lot of incontinence after stroke. And perhaps the two conditions that have the highest correlation with incontinence is sleep disordered breathing, so obstructive sleep apnea. It's very well proven that treatment of obstructive sleep apnea can oftentimes cure urinary incontinence symptoms both daytime and nighttime. And the mechanism for this is that when we have sleep apnea, we have increased thoracic pressure. And as a result of the increased intrathoracic pressure, our body starts to produce ANP, which makes our body feel like it's in a volume overloaded state all of the time. So like we're in heart failure all the time. And therefore our body's constantly trying to get rid of fluids. And so therefore we're urinating. And this happens, as I said, both in the daytime and the nighttime. So not only nighttime symptoms. And this is another thing that we can use to really try to encourage our patients to use sleep apnea. And I think all those who are considering for a possible diagnosis of sleep apnea, we should be specifically screening for urinary incontinence because incontinence is so high in this population. Also, we know that obesity is very highly correlated with incontinence. So again, this can be a little push. If they are incontinent, this can be another reason to try to encourage your patients to lose some weight. We know that there's a number of downstream negative effects that occur because of urinary incontinence. So patients with incontinence tend to have increased anxiety. They have reduced self-esteem, depression, social isolation. I see this a lot in my clinic, that older adults who used to be very social and used to really enjoy going out with family and friends really don't want to do so anymore, because they're always so worried about where the next toilet is going to be, or they're so concerned that they may wet themselves, and that would be a very embarrassing situation for them. There's a self-reported decrease in overall health, and certainly in nursing homes there is a variety of issues such as increased workload for nurses and rising costs. Both in nursing homes and the community, we see a decline in functional performance that's associated with incontinence, decreased mobility, and higher incidence of falls, as well as certainly in the most frail patients, impairments in oral intake, as well as hygienic and skin problems that occur when folks are really not able to manage their incontinence, and they're often leaving themselves wet. We also know that urinary incontinence is also highly correlated with mortality. So there was a systematic review done in 2016 that looked at 38 studies with over 150,000 patients from 19 different countries. And these patients lived in the hospital, in community, and in long-term care. They looked at all different types of incontinence subtypes, and they did a follow-up. These studies included a follow-up of anywhere from 4 weeks to 10 years. And in fact, only 3 of the 38 studies that were included in this trial did not show a correlation between urinary incontinence and mortality. And here's just the forest plot showing that the continence side favored survival in this group. And the other interesting thing in this study was that it was found that the more severe one's incontinence was, the higher the incidence of mortality over time. So the higher hazard ratios were found for those with severe incontinence. And we think that this is probably due to the interconnection of incontinence and frailty. So we know that frailer people are more likely to be incontinent, and also frailer people are more likely to pass away more quickly. But I think that we can use worsening urinary incontinence in our frail patients as perhaps a sign that things are progressing for them closer towards their end of the life as another marker. So things like we use normally, like perhaps not eating, losing weight, are signs of poor prognostic signs in our frail patients, as is perhaps worsening of urinary incontinence and more severe urinary incontinence. So despite how important urinary incontinence is, how prevalent it is, we are not doing a very good job currently at addressing continence needs for our older adults, and especially our frailer older adults. So we know that in the frail elderly, urinary incontinence is not often adequately assessed. So even in community dwelling elderly, the type of urinary incontinence is only diagnosed in about 48% of cases in this one study. And of course, we need to know what type of urinary incontinence someone has in order to actually know how to treat that incontinence. For more frail individuals in long-term care, it was found that assessments for urinary incontinence were only done about a quarter to a half of the time for patients. And of course, we know that incontinence is extraordinarily prevalent in residential care. Examinations are not done in the majority of patients. So for those with incontinence, only 15% had a rectal examination to look for fecal loading, and only 2% had pelvic examinations, which is actually a very important part of determining the cause of incontinence. In patients with dementia and urinary incontinence, it was found that in this one study that only 55% had care plans. And when we're dealing with patients with dementia and urinary incontinence, the care planning that is done by nursing teams is actually perhaps one of the most important things to make sure that people don't suffer from consequences of urinary incontinence, such as skin breakdown and falls. So I'd like to share with you a case example, and this is a patient who would be, a very stereotypical patient that I would see in my continence clinic here at St. Paul's on any given day. And I'd just like to walk you through the assessment that I would do on this older adult, and then walk you through the way that I would develop a treatment plan for this particular patient. So Mrs. S is an 84-year-old female. She's widowed. She lives alone in an apartment. She's had urinary incontinence for 5 years. This is, of course, the first time she's ever come forth to a healthcare provider, because she thought that perhaps this condition was not as important as her other healthcare conditions. And perhaps, there's nothing to be done because, well, many of my friends are incontinent, so maybe this is just a normal part of aging. But today she is coming forward. Her symptoms include frequency, so 10 times a day. She has some nocturia going 4 times per night. She has leakage that's associated with urgency. She has occasional leaking with cough and also with movement. So for example, getting out of a chair. She has no hesitancy, intermittency, or sensation of incomplete emptying. So no specific voiding symptoms. She goes through about 4 to 5 pads per day, as well as 1 to 2 pads at night. And she says the pads are pretty soaked when she changes them. She has no red flag symptoms like dysuria, hematuria, or recurrent UTIs. She has a soft bowel movement about 1 to 2 days, so no constipation. It's always whenever we ask questions about the bladder, it's absolutely imperative that we also ask questions about the bowel, because our bowel and our bladder are very close together in our pelvis. And if we have trouble with one, we have to exclude trouble in the other, because both will affect each other. In terms of fluid intake, she drinks 6 cups of water, 2 cups of tea, and 1 cup of coffee per day. She has a past medical history that includes type 2 diabetes, hypertension, chronic venous insufficiency. She has osteoarthritis in her hands and knees that cause her some pain, and she's had 2 falls in the past year. Her medication, so not too long of a list compared to some I see. She's on metformin, amlodipine, Lasix, celecoxib, gabapentin, and the favorite medication of geriatricians, being quite sarcastic, of course, is lorazepam, 0.5 milligrams at nighttime. So we know that there are a number of medications that are associated with urinary incontinence, hence the importance of taking a medical approach to incontinence to make sure that we've excluded medications that may be causing problems to patients. So some examples of medications that cause issues are both alpha adrenergic agonists, so these are things like clonidine, for example. We don't use this much anymore. Alpha adrenergic antagonists, so this would be something like tamsulosin, which we actually take advantage of in men to decrease smooth muscle tone in the urethra to make them be able to void more easily. ACE inhibitors, and this is more because they can cause cough, and certainly if people have underlying stress incontinence or pelvic floor dysfunction, this can lead to worsening urinary incontinence. Anticholinergics, so we'll talk about the fact later that we actually use anticholinergics to treat overactive bladder. So overactive anticholinergics will obviously cause impaired emptying and urinary retention, and we need to be very careful with these medications in people with underactive bladders, as we may run into issues with urinary retention in those patients. Calcium channel blockers, so calcium channel blockers, because we do have calcium receptors in our bladder, can also cause impaired emptying, and also more commonly cause peripheral edema. And if we have peripheral edema, the moment we lie down, all of that fluid backtracks up into our bladder, and we end up with a full bladder up urinating all night. And we see that our patient, Ms. S, is actually on a calcium channel blocker. So this is something we'll have to consider a bit later in our treatment plan. Cholinesterase inhibitors. So I think this is a really important one. We as geriatricians actually start not an insignificant number of cholinesterase inhibitors for patients that we diagnose with Alzheimer's or mixed dementia. But we really should be screening all these patients before for urinary incontinence, because cholinesterase inhibitors can increase bladder contractility and may precipitate or worsen urgency incontinence. And of course, those with dementia are more likely to have incontinence, and if that is a very troublesome symptom for them to manage already, starting a cholinesterase inhibitor may not be the right thing to do in those patients. In terms of diuretics, so we have a lot of patients on diuretics, and these may precipitate urinary incontinence. Lithium, opioids. So opioids do cause hypocontractility of the bladder and may cause urinary retention, as well as constipation, which can impair bladder emptying. There's a number of psychotropic medications, so sedatives, hypnotics, antipsychotics. So really anything that impairs your brain to be able to respond to the sensation to empty will cause problems. So for example, taking a sedative medication at nighttime will have an effect on your brain to be able to actually awaken to the response to void, and hence you may end up with enuresis or bedwetting as a result. SSRIs can increase cholinergic transmission, decrease urethral smooth muscle tone, and lead to urinary incontinence. And other medications that cause peripheral edema, such as gabapentins, glitazones, and NSAIDs, can also cause peripheral edema as well, and therefore lead to nocturnal issues with nocturnal polyuria. And we see that our patient is on a diuretic, she's on a sedative, so she's on lorazepam, and she's also on some gabapentin. So we have a lot of medications that we can look at perhaps changing around for our patient. So Mrs. S, so she has I, of course, always do a physical exam on all of the patients that I see, and it's very important to do a focused physical exam, specifically looking for urinary incontinence, for causes of urinary incontinence for these patients. And so I'll just walk you through what I usually do in my clinic for my older adults. So first of all, really the first step is I watch them walk into the exam room, and I really want to see their gait pattern, because obviously if their gait pattern is already a bit precarious, so they already are demonstrating poor balance on their way into the exam room, you can imagine what their gait pattern might look like as they're rushing to the bathroom in the middle of the night, right? And so thinking about the falls risk that they may experience once that sensation of urgency is felt. I watch them undress to see if they have good dexterity, if they're able to undo buttons, undo zippers. And I always say to my patients, there is absolutely no reason why somebody with urinary incontinence should be having buttons and zippers on their pants. I think elastic waistbands are perhaps one of the most useful things for people with incontinence. So because the few seconds that it takes to undo your button and your zipper on your pants may be the difference between being wet or dry. So elastic waistbands are definitely the friends of people who have problems with urgency. I watch their gait speed, again, to see how slow it is, again, to give me a sense of how they're going to be able to make it to the washroom in time. I do orthostatic vitals, because again, if somebody's getting up from a chair rushing to the bathroom and they're orthostatic, this can lead to falls. I look for peripheral edema, which can create nocturia. I test sacral innervation. So this is basically having the person in the left lateral decubitus position and testing saddle sensation at S2 to S4, because many of our patients have issues like spinal stenosis or other spinal cord issues that can lead to decreased sacral innervation and therefore difficulty with bladder emptying. I test anal wink, anal tone, and I do a DRE to see if there's any stool impaction within the rectum. I then do a vaginal exam. So on their back, I look for any vaginal prolapse. I look for evidence of atrophy, and I look for any skin breakdown, obviously, around the area that might suggest that perhaps they're having difficulty managing their hygiene with their incontinence. Perhaps one of the most important tests to do with a patient with urinary incontinence is testing their pelvic floor muscle strength. And this is for women, just putting your finger right at the base of their vagina and asking them to squeeze or try to pull your finger up into the vagina. And it's very common for older women and older men to perhaps have lost some of the awareness of how to contract their pelvic floor. And so people will start to shrug their shoulders and they'll start to squeeze their buttock, but really there's nothing going on in their pelvic floor at all. And so if you're to go tell that person to go do Kegel exercises, they're probably going to end up with really strong shoulder muscles and bum muscles, but they're really not going to end up with very strong pelvic floor muscles at all. So for these patients who really have lost awareness of their pelvic floor or who really have very weak pelvic floor muscles, pelvic floor physiotherapy, as we'll discuss later, can be very beneficial. I do a stress test, so that's basically asking the person to cough to see if they leak, and that's very suggestive of stress incontinence. I look at the post-void residual to see if perhaps they are in urinary retention, and then sometimes I will also do cognitive testing on my patients if I suspect there's cognitive issues, because that can tell me more about treatment plans and what kinds of things I'm going to suggest at the end of the day. In terms of investigations, there's actually not that much that I order. It's always good to have a recent GFR, as well as a hemoglobin A1C for all of those who have diabetes specifically. And we see here that Mrs. S's hemoglobin A1C is actually quite high, even for her age. I will always do a urinalysis on patients, and usually if their urine culture is positive, I will treat it once because they've come to me with a symptom being urinary incontinence. I'm very careful though to not continue treating incontinence if the patient gets no benefit in terms of their incontinence after treating that positive culture, because we know that so many of our older patients have asymptomatic bacteria. And so if I treat the quote unquote urinary tract infection and there's no improvement in their incontinence, then that person likely has asymptomatic bacteria. And it's good to be able to document that for the future so that they're not recurrently treated for the same issue. There is really not good evidence that cystoscopy or urodynamic studies are necessary for most older adults, unless there's red flag symptoms. So certainly anybody with hematuria should go on to get a cystoscopy to look for bladder cancer. Those with complex neurological diseases, it can be a little bit difficult to determine what's going on with their bladder. Is it hyperactive? Is it hypoactive with overflow incontinence? Anybody being considered for surgery, so women contemplating surgery or men with what we feel is BPH symptoms being assessed for surgery, should go on to have urodynamics in most cases to make sure that we actually understand what their primary issue is and that the surgery is beneficial to them at the end of the day. But most patients, especially those who come to us with urgency incontinence, do not need to go on to more complex invasive investigations. So what type of incontinence does this patient have? So we heard from Mrs. S earlier that she was having urgencies associated with her leakage. So she does have urgency incontinence. We heard that she was having issues when she was standing or coughing, that she was leaking a bit of urine, and her stress test was positive on the physical exam. So she does have stress incontinence and functional incontinence. And so functional incontinence really means anything outside of the bladder that we feel is maybe creating incontinence for this patient. So we know she has a slow gait speed. We know she has some arthritis that may be affecting her ability to get to the washroom and undress in time to be able to void in the toilet. And so Miss S really has multifactorial incontinence. And by far and away, the most common diagnosis for older adults for their incontinence is that they have multifactorial incontinence, just like most geriatric syndromes that usually are multifactorial in nature. And so when we're developing a treatment plan, it's very important to break down each type of incontinence they have and decide why they have that type of incontinence, so that we can really form a treatment plan around each different type of incontinence and figure out what we're going to do about each one separately. So as mentioned, we know that Ms. S has overactive bladder or urgency incontinence. So what might be causing this? So she's on Lasix. We don't really know why she's on Lasix. She doesn't have a history of heart failure that we know of. She does have some peripheral edema, but there may be other ways that we can manage that. She has polyuria due to excessive fluid consumption. She's drinking lots of caffeinated beverages, so tea and coffee, that we could perhaps decide if we want to tell her to reduce those a little bit, or at least give it a shot. She does have poorly controlled type 2 diabetes, so she may be having excessive urine production due to glucosuria. The next problem she has is nocturia. So we know that already, as we mentioned before, she has peripheral edema, she has venous insufficiency, and her peripheral edema may be at least somewhat due to the fact that she's on NSAIDs, calcium channel blockers, and gabapentin. So we may want to look at perhaps changing those medications up a little bit. She has enuresis, or nighttime bedwetting, and this may be due to the co-administration of a sedative at nighttime, so she's not able to actually wake up to the sensation to void, and also the Lasix that she's taking. She has stress incontinence, and we found during our physical exam that she does have quite weak pelvic floor muscles that could do with some work. And then she has functional incontinence, so she has arthritis, she has slow gait, and we found that she also has orthostatic hypotension, which may be making her feel pretty dizzy as she's going to the toilet. So now, before we get back to Mrs. S's case and how we decide to treat her at the end of the day, I would like to review some of the non-pharmacological treatments that have evidence for urinary incontinence. And for this, before I start this section, I would like to start with a poll question. So this is the second poll question for today. So what lifestyle interventions have been shown to be effective in the treatment of urinary incontinence? So we have 4 choices here: reducing total fluid consumption, avoiding acidic drinks, avoiding alcoholic beverages, or weight loss. So I'll just give you guys a few minutes to answer that question. Okay, so a bit of a split panel here. So we have the most choice is a D, so weight loss at 75%. But we also have 57% for alcoholic beverages. We have 28% for acidic drinks like orange juice or grapefruit juice, and we have 36% for reducing total fluid consumption. So very interesting. So really the answer to this question is D. So weight loss by far, and I think I mentioned this in an earlier slide, so I gave you a bit of a hint. Weight loss certainly is a medical, obesity is a medical condition that is certainly correlated with urinary incontinence. And there's a Cochrane review looking at lifestyle interventions for urinary incontinence in older adults back in 2015. As you can see here. And unfortunately, the quality of evidence for lifestyle interventions is not all that great. So there's been not all that many randomized controlled trials looking at lifestyle interventions. But the 4 trials for weight loss interventions were all positive trials showing that weight loss and losing weight of even 10% of your body weight can lead to a 50% reduction in urinary incontinence. So again, this can be a really great motivator for those who are overweight to lose some weight if they do have associated incontinence. So the other trials, so decreasing fluid intake, decreasing caffeine, and for whatever reason, I'm not sure why they did this study, eliminating soy, these did not have, these interventions did actually not show to be beneficial in reducing urinary incontinence. So just to the fluid intake point, because there was quite a few people who felt that decreasing fluid intake might be a good thing for incontinence. We know that in older adults, they often try to limit their fluids significantly. So they'll say, you know, the days that I know I have to go out, I really don't want to go to drink anything because I'm afraid that I'm going to need to go to the toilet. But actually the uroepithelium, or the lining of the bladder, is actually a pretty active substrate. And if it's seeing very concentrated urine, so urine that doesn't have enough water in it, that concentrated urine really irritates the uroepithelium, or the lining of the bladder, and can actually make urgency incontinence even worse. So the goal really is to get your patients drinking 6 to 8 cups of fluid a day. And this can be a bit of a difficult sell, because intuitively it makes sense that I drink less and I pee less, but actually most older adults don't drink enough, and we want them to get into that 6 to 8 cup range so that their urine concentration is adequate, and that they're not having overly concentrated urine that's really irritating their bladder. In terms of other lifestyle interventions other than weight loss, there's not great evidence. And so first of all, there's not a lot of randomized controlled trials out there anyways, but for these specific interventions, so first of all, physical activity. So physical activity, there's some non-randomized controlled trial evidence to suggest that moderate exercise may decrease urinary incontinence or overactive bladder symptoms. But again, no real high quality evidence to suggest this. I think physical activity is probably the #1 best intervention for older adults for a number of reasons, cognitively, from a mobility perspective. So I think it's fair, obviously, to be counseling on our patients about this anyways. Smoking. So there is some, again, non-randomized controlled trial data to show that smoking abstinence can improve urinary incontinence symptoms. And again, this is something that we're going to be encouraging our patients to do anyways. Caffeine. Now, caffeine's a bit of an interesting one, because many of us anecdotally, we say, oh, whenever I drink that venti coffee from Starbucks, I'm going back and forth to the toilet all day. But there's not a ton of evidence to suggest that caffeine is a real major player. Certainly smaller amounts of caffeine. So anything less than a venti of Starbucks a day, because I've looked up the number of milligrams quoted in the trial. So anything less than a venti coffee a day shouldn't really be causing people that much trouble. So if you're drinking a venti cup of coffee or over, that may cause you some problems. But anything less than that, I'm not really sure. And we know that a lot of our older adults really love their cup of tea or their cup of coffee in the day. And if it's only, 1 cup, cutting back on that probably is not going to be a really important intervention. Constipation. So certainly see a lot of people with constipation, so a lot of older adults with constipation. And we do know that there is association between chronic straining and urinary incontinence, likely due to damage of the pelvic floor. But also, if your bowel is super full of stool and it's pushing against your bladder, you have to think that that's going to create either hypoactivity or perhaps in some cases hyperactivity of the bladder if they're already predisposed to this. We just don't have any good studies on this to actually quote in terms of high quality evidence. But I think in practice, we certainly think this is an important factor. So for the frail elderly, so all those things I mentioned earlier were kind of community dwelling elderly. In the frail elderly, really there's no lifestyle interventions that have good evidence, probably because the frail elderly are hardly ever studied in any trials, let alone continence trials. But again, the best evidence for the frail elderly is really increasing hydration to ensure that the urine concentration is appropriate. And this can be tough in the frail elderly, but this is what we should be striving for in terms of a lifestyle intervention for our frailer patients with incontinence. So fortunately, there is better evidence for behavioral interventions over the lifestyle interventions that we just discussed. So the first one, pelvic floor muscle training. So pelvic floor muscle training is an amazing intervention for incontinence. And so we know that pelvic floor muscle training, either as a standalone treatment or a part of a multi-component strategy, is very effective. And in fact, there's some evidence to suggest that it's just as effective as drug therapy, and that the combination of drug therapy and pelvic floor muscle therapy may be more effective than either treatment alone. Supervised pelvic floor muscle treatment is the best, and this is because of at least partly because of the issue I told you earlier, that a lot of older people have lost that coordination of the pelvic floor and really need some guidance with a pelvic floor muscle physiotherapist using either biofeedback or manual techniques to really gain a sense of where their pelvic floor is and how to contract it appropriately before they can do Kegel exercises and other pelvic floor muscle exercises appropriately. But this should be offered as a first-line conservative therapy for women of all ages with urinary incontinence, and this is a level 1 recommendation. Other behavioral interventions that have good evidence are bladder training. And so bladder training really means trying to get your brain back in control of your bladder. So sometimes, when people develop urinary incontinence, they get into these bad habits of continuing to go to the bathroom every 15 minutes. They're going back and forth and back and forth and back and forth. And the point of bladder retraining is really to have our frontal lobes develop more control and to recognize that our bladder can actually hold more than we think it can. So you start, by telling people, first of all, I want you to start going to the washroom about every 45 minutes. Every 45 minutes, go sit yourself on the toilet. The next week, stretch that out to an hour, then 90 minutes, and then 2 hours. And really, you're wanting to get to the point where people can last about 2 to 3 hours between voiding. And this can be a really great intervention because this will allow people to be able to go out for longer times without having to find a toilet, and is very effective. It is best done with a supervising healthcare provider, for example, with a nurse continence advisor who can really walk them through the steps of this and also give them a log or a diary that they can review with the person to see how things are going. Sometimes, though, this does not work for people. So if you're really not seeing any improvement after 3 weeks, you can probably abort the mission, but it should be tried as a first-line therapy. And there, again, is some evidence to suggest that bladder retraining is as effective as drug therapy as well. The next behavioral intervention is timed voiding. So timed voiding is basically every 2 hours you go sit yourself on the toilet. And there's really not a lot of evidence to support this in cognitively intact women, unless you're doing bladder retraining, and that's the point of the bladder retraining exercise. But the point of bladder retraining is to stretch out the time between voids and not to have that need for such frequent and rigid voiding. Timed voiding is a first-line intervention for those with dementia. So basically in care homes, nursing staff taking people to the washroom every 2 hours to hopefully prevent some of the skin breakdown that's associated with constantly being wet. So no evidence in cognitively intact older adults, but can be a suggested measure in those with dementia. So I'd like to go back to Ms. S now that we've had the opportunity to discuss some non-pharmacological treatments. So first of all, really we want to try conservative management with Miss S. And, as I mentioned before, things like pelvic floor muscle training exercises and bladder retraining actually have just as good evidence as drug therapy that they can be as effective as treating urinary incontinence symptoms. So in terms of what we want to try for Miss S, so as I mentioned, there's not a lot of evidence that smaller amounts of caffeine really cause a lot of problems with the bladder, but she's drinking 2 cups of tea, a cup of coffee. So it may be worth saying, if it's not a big deal for your quality of life, why don't you try cutting down one of those cups of tea or that cup of coffee to see if it makes any difference for your bladder. Try it for a week. If it doesn't make any difference, then you can just go back to doing your thing with your same caffeine intake. But it may be worth a try. Physical exercise. So as mentioned, there is some non-RCT evidence to suggest that this is helpful. And I think for this particular patient, she has a slow gait speed, which is an independent predictor of falls and mortality. So we would really like to see her being able to improve her gait speed and also do some balance exercises to be able to decrease her falls risk. So perhaps having her see a physiotherapist would be a great idea for her. Certainly referral to a specialized pelvic floor muscle physiotherapist, I think would be an excellent intervention for Miss S because she had very weak pelvic floor muscles, a lack of pelvic floor muscle coordination. So she may really benefit from this approach to see if she can strengthen her pelvic floor so she'll be able to have more control when she feels that urge. She would need some instruction and some self-management tools for bladder retraining. So I would, in my clinic, for example, I would have her go see our wonderful nurse continence advisor for some assistance with this. And then a medication review, which is very important for her. So the first thing I would do, I would taper her Lasix. I don't think there's any indication for that. And I would try my very best to get her off her lorazepam. I would replace her NSAIDs with acetaminophen, as the NSAIDs may be causing some edema. I would replace her amlodipine with some ramipril, and I would use a lower dose of antihypertensive because she already has orthostatic hypotension, and we want to make sure that we eliminate that. And then we need to optimize her diabetes control, because even at her age, her hemoglobin A1C was far too high. And so perhaps by controlling her diabetes a bit better, we can stop some of her glucosiuria and increased urine production. And then there's the question of pharmacological treatment. So for most patients with urinary incontinence, especially elderly patients, I really think that a 6 to 8 week trial of non-pharmacological treatment is most appropriate for these patients, in the majority of situations, because we do know that non-pharmacological treatments can be very, very effective. And so why bother our patients with increasing numbers of medications if perhaps they can get to an acceptable treatment level with non-pharmacological treatments? There are some people who we may want to consider starting on pharmacological therapy concurrently with non-pharmacological therapy, and this may include younger patients, so those less than 65, as this age range is more commonly studied in our trials, and there's more evidence about the adverse effects, and we know that there are fewer adverse effects in younger patients. Those with fewer comorbidities and fewer medications have found to have less trouble with certainly anticholinergic medications in several trials. Those who are cognitively intact, so for anticholinergic treatments, we actually have no studies to show what these drugs do in those who are cognitively impaired, and so we have to be very careful using those medications in this population, and we'll talk a little bit more about that. Those with severe bother as well, so if they've been going on with this condition for a long time and they're absolutely desperate, you can discuss the risks and benefits of medication treatment earlier. There's two targets of therapy for urinary incontinence treatment. There's reducing the strength and frequency of bladder contractions through antimuscarinics, or a second line option being Botox injections into the bladder, and then enhancing bladder relaxation by our newest kid on the block, mirabegron, our beta-3 receptor agonist. Here's a list of the currently available antimuscarinics that you guys may have seen out there, and also our beta-3 agonist, mirabegron. So this is a slide, and I think this is very, very important in older adults specifically, because we as geriatricians do worry a lot about anticholinergic side effects and anticholinergic burden, but not all anticholinergics, especially those created for the bladder, are equal in their potential effects to create cognitive side effects related to anticholinergics. So you'll see here that oxybutynin is a very small molecule. It's very lipophilic and it's neutral. So it very easily crosses through the blood-brain barrier. The other medications, some of them are a bit bigger, some of them are less lipophilic, and the three on top actually have a PGP transporter that if any gets across into the CNS, it'll get bumped back out into the vasculature and out of the CNS. And so really, in my opinion, oxybutynin should not be used in the elderly, and particularly the frail elderly, because we do know, and there's good evidence, good clinical trial evidence to support the fact that oxybutynin does cause confusion and altered mental states in our older patients. And I just want to share with you quickly the Lutz FORTA criteria, and this was developed for lower urinary tract symptoms, especially in the context of older adults. And so for those of you not familiar with the FORTA classification, Class A drugs are drugs that work and drugs that are safe. Class B drugs are drugs that work, but we're not really sure about safety. Class C drugs, we're not really sure if they work and we're not really sure if they're safe. And Class D drugs are drugs that we should just not be using in the elderly. And I actually prefer the FORTA classification over the Beers criteria, just because in the Beers criteria, pretty much every medication that we use, we're not supposed to be using in the elderly for one reason or another. And I think the FORTA classification does a better job at balancing efficacy and also side effects at the same time. So if we look at the FORTA classification for our drugs for overactive bladder, oxybutynin, immediate release oxybutynin, should never be used in the elderly. So as I mentioned, I just don't use this in my older patients. Most of the others are in Class C, and then we have fesoterodine that makes it up to Class B. And the reason for this is that there's been only one study with anticholinergics specifically tested in a frail population of older adults, and that was with fesoterodine. And it showed that it was just as efficacious in this frail elderly group, and the side effect profile was not significantly more than in younger people, and there was no statistically significant higher incidence of cognitive side effects with fesoterodine in this frail group. It was a frail group of cognitively intact older adults, but it was a frail group nonetheless. These other drugs that you see here have not been tested in the frail elderly, so we're not sure what they may do, but that's why they end up in Class C instead of Class B. And then if we look at for men, we haven't talked a lot about men today. I wish I had more time to go through a case of a man as well. But for our medications for BPH, dutasteride and finasteride end up in Class B, with tamsulosin ending up in Class C, mostly because of its effects on orthostatic hypotension and increased falls risk. And then the Class D medications are your other alpha-1, so things like doxazosin and terazosin, which are not preferred in older adults. Instead, Flomax does have a bit of a safer profile for our patients. So one last poll question before I'll start taking your questions. Would you start Miss S on drug therapy? Yes, I would start on oxybutynin. Yes, I would start her on fesoterodine. Yes, I would start her on mirabegron. No, I would not start her on any pharmacological therapy. So I'll give you guys a second there. Okay, this is it. This is very interesting. So 88% of you would not start her on any medications for urinary incontinence. Very interesting. 2% would start her on mirabegron, 8% would start her on fesoterodine, and 2% would start her on oxybutynin. So I think this is a bit of a trick question because I think either B, C, or D, I would not start Mrs. S on oxybutynin. She's elderly. There's good evidence that in elderly people, oxybutynin has a worse side effect profile. But I would consider starting Miss S on either fesoterodine, mirabegron, or not starting on treatment at all. So first of all, I would definitely embark on the 6 to 8 week trial of non-pharmacological treatment. But after that, if she really felt that her symptoms were bothersome after that time, I would talk to her about the side effects of these medications. So for example, fesoterodine is an anticholinergic. It can cause dry eyes, dry mouth, and constipation. So if she had problems with any of those things beforehand, I would probably opt not to start that medication. If I talked to her about mirabegron, I would talk to her about side effects such as worsening hypertension, and certainly if she had uncontrolled hypertension, which was not a problem for her initially, I would certainly not consider her for that medication, but mirabegron would be an option. And I may also talk to her about the side effects, and she may say, you know what, I'm not interested in any more pills. I want to keep pushing ahead with the non-pharmacological treatments. And I've certainly had experiences, all three of these experiences with patients, either not wanting to start more drugs or wanting to give it a try with either an anticholinergic or mirabegron. So I don't think either one of those choices are wrong, but I would avoid oxybutynin. I should say here in BC, oxybutynin is the only one that we can actually get covered through our BC Pharmacare. We can get special authority for solifenacin, but fesoterodine and mirabegron would not be covered by Pharmacare, and hence that is a big issue in the decision process as well about starting drug therapy. So with that, I think we're pretty much through here. I'll just scroll through to the end of my presentation because I think I have one last slide to end off with. Sorry, my presentation closed there. It's a slide that you guys have seen before that I just want to reiterate again. So please spread the word. Urinary incontinence is not a normal part of aging. We want patients to be coming to us with their continence problems so that we can address medical issues, medications that might be contributing to their incontinence, and referring through to appropriate resources such as nurse continence advisors, pelvic floor physiotherapists, and when needed, specialized continence clinics as well. So thank you very much for your time, and I would be more than happy to take questions.
Thank you very much, Dr. Spencer. So that was very informative, and I know our audience probably has some great questions out there. So please use the chat box and start typing your questions now so Dr. Spencer can answer them. Let me see one that's coming now. So the question in the chat box is, what is the difference between Tamsulosin CR tablets and the SR capsules? Is there any reason for choosing one over the other?
Actually, I don't even know if I've never used the CR capsules. This is for Tamsulosin specifically, I guess. Yeah, I've not used the CR capsules. I would probably choose the former, so just the Tamsulosin, the regular formulation, the 0.4 milligram regular formulation, just because I probably wouldn't choose a long-acting formulation of a medication that has the potential to cause significant orthostatic hypotension in the elderly, because we as geriatricians see this all the time as a cause of orthostatic hypotension and falls. So I think you do have to be careful of Flomax or Tamsulosin, and I would always use a more immediate release formulation than a controlled release medication that may stick around a bit longer in our older adults.
Okay, and other questions here. What age group does Dr. Spencer deal with?
That's a great question. So geriatricians in general, we usually see people over the age of 65 as a rule. I would say that most of our patients in our general geriatric clinic are in their 80s and 90s. 70 is considered pretty young for us. In my continence clinic, though, I see people of all ages. So our continence clinic is opened up to all ages. We're a self-referral clinic or a healthcare provider referral clinic. So physicians, nurses, case managers in the community can refer, and people can also self-refer themselves, and we accept people of all ages. I would say in general, most of our patients are in their their 60s, 70s, but I saw a 100-year-old lady the other day as well. So we see people of all ages here in this clinic.
Great. Another question, I really appreciate the FORTA classifications. This is something for further research review for me and my team. Thank you for bringing it to our attention. Sorry, that's a question, not a comment. But there is another question here regarding a 100-year-old frail lady. Someone's wondering if a bladder prolapse for a 100-year-old frail lady can explain her UI.
Yeah, that's a really great question. So bladder prolapses themselves do not usually cause incontinence per se. There are some cases in which the prolapse is large enough that it's actually obstructing their emptying. And in those contexts, when they void, they get obstruction from the prolapse, and then they stand up, and then they move around a bit, and they end up leaking because the urine had been stuck behind the prolapse. So it's kind of a more of an obstructive issue. Usually, though, putting in a pessary is really done for people with prolapse who are obstructing, because that can lead to problems with urinary retention and then more upper tract problems. But in general, if people are not obstructing from a prolapse, putting in a pessary is only done if the person has symptoms from the prolapse itself. So they can kind of feel it rubbing against their legs when they're walking, or they find that when they're upright, it's very uncomfortable. They feel a really heavy sensation between their legs. So in that context, trying a pessary is a good idea. And the nurse continence advisor in my clinic definitely puts in pessaries for that indication. There are pessaries, for example, they're called incontinence rings, stress incontinence rings. They actually don't have much evidence to actually help with incontinence per se. So generally, if we're just talking about incontinence without obstruction, putting in a pessary may not help with incontinence. And as a side note, I actually have put in pessaries in people who probably have some degree of obstruction. They have no increased PVR, but maybe their prolapse was obstructing a little bit. And when you remove that obstruction, people's urinary incontinence actually gets worse in some cases. And so that's why it's always a good idea, and perhaps a good to put in a pessary first before you go for the surgery, because at least you can take out the pessary if it creates more trouble than it was worth. But once you do the surgery, there's no going back. So that's something to think about. But this interplay between prolapse and incontinence is interesting, but I think the take home is prolapses themselves do not usually cause urinary incontinence unless they're obstructing.
Okay. The person who asked that question then added they meant bladder diverticum, sorry, not prolapse. Would any of your recommendations relate to that? The question about the bladder prolapse was actually meant to be about bladder diverticum.
And if there's any evidence for
if that would cause UI for a 100-year-old frail lady.
So bladder diverticulum, does he mean, I'm not sure perhaps if he means trabeculations in the bladder or diverticulum. So diverticulum or trabeculation sometimes are a consequence of long-standing back pressure in the bladder. So we'll see that, for example, in people who have BPH, they'll end up with diverticulum and trabeculations. But just having the presence of diverticulum should not be a major cause in this person, and I wouldn't probably recommend chasing that down much further.
Okay. If a patient is asymptomatic for UTIs, what is your management approach as a primary care provider? Any tools or resources you recommend for primary care?
Yeah, so I think that's a really great question. So I actually get quite a few referrals to the clinic for recurrent UTIs. And I would say more often than not, the patient does not have recurrent UTIs, they have asymptomatic bacteria. And so I would suggest not treating these people. I would suggest getting blood work. So if a person starts to have what they consider to be symptoms, and these can be things that are very non-specific, but if a person considers having quote unquote symptoms, I would get them to do blood work at the same time. So I would get them to go and get a white blood cell count and a CRP. And if these are not elevated, then that's an extra thing that you can use to reassure the patient that actually they don't require antibiotics. And we know that even if a person has a pretty mild cystitis, most people are able to clear that on their own. And it's very unlikely that that's going to go on to cause, a really significant infection. So I think we way overuse antibiotics for quote unquote urinary tract infections. And I think unless somebody comes in with very overt dysuria or, systemic symptoms like fever, I would elect not to treat and to just observe, because we're learning more and more about the microbiome and the microflora in the bladder. And I think all the antibiotics we're using are disturbing that and leading to further antibiotic resistance. So I would say, try not treating it and do some blood work and monitor the patient rather than doing the reflex thing of starting antibiotics, especially for people with these non-specific symptoms.
Great. So we're actually at the top of the hour and we still have questions coming in. Many of them are relating to drug therapy. And what I'd like to recommend is that we'll have Dr. Spencer review them. And I'd also like to announce that we're working on some education for clinicians with Dr. Spencer. So we may be able to include some of these answers in that information. Thank you to our audience for attending. And thank you, of course, to Dr. Martha Spencer. This was very, very interesting and enlightening. For the audience, we encourage you to take a few minutes to complete a quick survey that will be emailed to you. And please join us at our upcoming webinar on Friday, February 22nd from 12 to 1 on Geri Medrisk. There'll be more information coming about that webinar in your inbox soon. Thank you again. Have a wonderful day. This is RGP signing off.
Thanks so much, everyone.